Welcome back.
Hey guys.
Good to see you, Greg.
Good to see you.
We're here at Healthier Ever After, and I think we're excited tonight. We're going to actually do a multiple episode with a lot to talk about, and I don't think we're going to get this done. We don't want to, put out a 4-hour episode, but we got a lot of things to talk about. We've been talking the last couple of times. We've been talking about male hormones, testosterone, and what we're going to move to today is women's health and. Some issues with estrogen and things. Again, we reiterated this before, but makes it's even more important to remember that the things we're discussing tonight and for the next couple of weeks is really important that you discuss things with your primary care or personal medical provider. This is for informational and educational purposes. We are medical providers, but we are not your medical provider, and it's extremely important that you kind of have that relationship and ask questions and talk to your provider before starting any program, particularly if it involves hormone replacement or anything like that.
It's not definitely something you don't want to be willy-nilly with on this one. There's a lot of information online and frankly a lot of good information and a lot of bad information, and really it's a lot of times it's more the context, right? Like if you don't have context with what you're doing or what you're treating, then it definitely should be something you are discussing with your medical provider.
And now we've tried our technology again. We've got another guest for these episodes. Bring her on. This is Caitlin Robinson, and she is so she's a nurse practitioner. We've worked with her for years in the emergency department. But Caitlin, you've been around. You were like a wilderness firefighter and the weird stuff, and then a nurse, and now you're a nurse practitioner. And really, I think the reason we invited you here because we both know you and know how passionate you are about kind of these topics that we're talking about, women's health and hormones and things like that.
That's correct. Yep, I agree.
Not to mention, who wants to listen to me?
A couple of guys talking about right.
A couple
two
of
males
dudes.
that you're going on about female hormones. So we've both worked with Caitlin, and Caitlin's a provider that I work with actually at my clinic, and it just every single time someone meets with her, we just hear so many great things. So we thought rather than keeping her hidden away in some office that we'd put her out here and ask her some questions and get some insight from her perspective on all kinds of different things in regards to the history and how hormone replacement kind of is where it's at today.
And it's a thing, and it's interesting because this is one of the things that I think we've seen a major shift in the last few years from what we've done. So what we wanted to talk about tonight really is kind of the history of female hormone replacement, and this all started back in the 1960s. Dr. Robert Wilson's 1966 book called Feminine Forever talked about hormone deficiency as a disease, and throughout the 1970s and 80s, estrogen prescriptions climbed, and steadily women and their doctors embraced the idea that hormones could ease symptoms and protect bones and possibly the heart, and so this was kind of what was happening. That was the medical field, and then happened 2002, the Women's Health Initiative study.
Right. Yep.
You want to comment on that?
I do. I got me some good comments on that. I think the important thing to know about the Women's Health Initiative was it was set up to be this big, gorgeous research project that proved that women should be on estrogen. So it was really coming from a good place in society. Medical community was like, hey, let's have one gorgeous research project that locked it down that we should be getting estrogen replacement and progesterone replacement. And, it was great. It's a great concept. And they just set it up, got rolling with it, and then went ruh-roh. We did not do well with this. And they didn't, and then it took 20 years to dig out all the different problems that came with that big project. So I think number one, they were trying to help women out. They were really trying to look at it as preventative health, and they were trying to do us a favor. Just the way it was set up was not.
Now, if I recall correctly, this was 2002, and the study wasn't really necessarily bad, but it was set up in a way that made it not generalizable to really perimenopausal women. They studied older women. The population was different, and I think it was more of an issue of how it was reported, what the media said about this. And essentially the message was, if you replace your hormones, you're going to die of breast cancer and heart disease.
Right.
Like it was that almost like that, Frank.
Yeah, that's what they were saying really quickly into the research project. Was about 9 months into it, they were starting to already see like, whoa, we're seeing some crazy cancer rates. So they canceled the whole thing a lot earlier and then reported the results. But the biggest issue is they had three biggest issues. They picked the wrong meds. They didn't choose bioidentical, and we did have bioidentical medications back then. They picked the wrong study patients. And back then, they were really focused on women who have been 1 year without a menstrual cycle or a period, which deems you in menopause. So they really wanted that hard line, which is fair. You kind of have to have some rules to a good research project. And then they underestimated that the illness trends in a woman's life from 40 to 60 years, that's a huge shift in a time frame for a woman. And a lot of chronic illness builds and festers and builds and festers, and then boom, after 60, that's when we see a lot of these big issues. So those are my big three things that, and most clinicians will say those are the big
so we're talking this study was reported as having some good evidence that says, hey, this is really bad, but it was looking at women who had already been through that whole 20-year process, not what to do during or before or around that time. Just we're looking at women after all this has already happened, and that made it a little bit difficult to apply to kind of that all the women in that 20-year period where you're going through menopause or you're premenopausal.
Right. They were choosing women, and vast majority of the ages of these women were over 60 years. So, relatively speaking, they were about 10 years post menopause. So after the 10-year mark. And a lot of them had never had hormone replacement at any point in their life. So from 40 to 60, when their estrogen's declining, till 60, and then they hit menopause, say 50, just for round numbers, and then to 60, they might have had little breast nodes that were a little festery, that might have turned into cancer. They might have had some endometrial stuff turned into cancer. They might have already had cardiovascular illness and plaque laying down in their arteries in their heart. And then boom, we throw them into this trial after 60, and we throw them into estrogen and wake their cells back up and say, hey, do your best. And then they're like, whoa, we're already behind the mark.
Station.
Yeah. Like you just woke up beasts that were sleeping. And so really and when the vast majority of these women were over 60, hadn't had any hormonal replacement, they're, post-menopause for years, to give them hormones and wake their bodies back up, wake them up out of a sleeping beast per se. And then, of course, your study is going to say, hey, you're causing cancer, you're causing cardiovascular disease, you're causing, endometrial cancer, all these things. Well, it probably would have already been happening. It was already kind of sitting there. So we just don't know. But it's frustrating because that one study, they picked the wrong patients. They didn't, they didn't really pick these women in their age.
Were massive. Like almost overnight, estrogen prescriptions just stopped.
Preventative health care for women took an absolute face in the brick wall. I mean, it just shut things down. I've even heard stories of women who were on hormone replacement, very good, low doses, safe doses. They were tolerating it very well. And then when this women's health study came out in 2002, their doctors literally called them at home and said, hey, stop taking that medication. I'm canceling your prescription. Like overnight. It wasn't like finish it was hard stop. And these women were thrown. Now these medications are keeping their symptoms at bay, managing their symptoms really well. Overnight, these women are going from feeling pretty good, relationship stable, they feel good mentally, to hot flashes, sleeping terribly. I mean, it was right into menopause. It was not gentle, and it was pretty cruel, pretty aggressive. So
the thing that jumps out to me, Caitlin, that I think, because me and you have talked about this study before and how frustrating it is to watch back in time. It's easy to, look back in time now and see how bad it was, but is that it was what, 40 years of growing evidence that this is a good thing and
Right.
that it's great for
Yes.
management of symptoms and we're not
Yeah.
really having any issues. And it takes one 9-month study that we
Right.
all agree now and look at that there was
Right.
probably correlation but no causation, wrong
Right.
study, participants. And
Right.
so the lines in the sand that were drawn for this study were just the wrong lines.
Just wrong.
And instead of actually saying, hey, let's do something different, let's do another study, let's look at 40 years of anecdotal evidence with some studies as well. We're going to throw all that out for one study.
Yeah. And we did that for 2 decades.
Yeah. And it's taken 2 decades to dig out what were the problems with this study. And don't get me wrong, even bad research is good information to some extent. So we did learn some things. Hey, if there's a woman who's been menopausal, so hasn't had a period for 1 year, for at least 10 years, it's probably not safe to start hormone replacement. It's a good guideline. So we've gotten some of those things. We've also gotten, hey, if you've got abnormal uterine bleeding, so like you're bleeding vaginally and we don't know why, you're postmenopause, that's a good thing to check out. If you've had any breast nodes, if you haven't had a mammogram recently. So there's a lot of things because we're looking for those little things that maybe have hung in there, festered, because if we wake your body back up, we don't know the damage we could do. So even bad research does give us some information. We know which meds to use. We know not to use Provera, which is, Premarin, which is the estrogen that's derived from horses.
Yeah, I was going to ask about that. Like you mentioned, you talked about like what they had used in this study, and if I remember, it's medroxyprogesterone acetate combined with conjugated equine estrogen. That's horse estrogen, right?
It's horse estrogen. And so I don't know. And that's the thing. We did have bioidenticals available back in, the early 2000s.
When you say a bioidentical, help our audience understand what you mean.
Estradiol and micronized progesterone. So those are like chemical names, the medroxyprogesterone acetate. Those are all compounds. That's a synthetic progestin. And then estradiol is the most bioidentical. So when I say bioidentical, the most similar to what my body makes, I want my external hormones, the pills that go in me, to resemble that the most, because I want my cells to recognize.
I think it's an important note, to remind us that's what we're talking about.
Right. And it's when you use synthetic hormones and things and horse hormone or hormones from other animals, for example, that's not necessarily the closest to what I make. And so my body's not going to know what to do with it. My cells are going to say, hey, your key, for example, the hormone, is not going to unlock this lock. It's not going to work on my cells. And so I think that's pretty important. And we did have those back then. They chose to use those medications. I'm not sure. This is all speculation. If it's because they were cheaper, they knew it was a big cohort, a big population of people they were using. I'm not quite sure why. But when all these little things combined, we now know, hey, don't use synthetic hormones if you're doing hormone replacement. Birth control is a different option. That's a whole different topic. But when we're doing hormone replacement and we're just doing these tiny doses to keep women's hormones stable, bone safety, symptoms at bay, the best thing to use is the most bioidentical hormone form. So awesome. That's another thing we learned from it. So we
learned that. And then we talked about the women in the study were on average 10 years beyond menopause.
At least.
And so it seems like that's one of the other things that we learned, or we've learned, I guess, in subsequent research, is there actually is a good time to start this, that, women in their 40s and early 50s actually do get benefit. And in all kinds of things. And women who start this in their 60s probably don't. But that was kind of a distinction that we were missing.
Yep. And it's all individualized, right? I mean, like no woman is cookie cutter. Yeah, we might resemble menstrually, like what our mothers do or something, but every woman's different. It should be patient-centered. We should be talking to every woman and weighing risk and benefits, right? So, even 5 years ago when I was first learning about hormone replacement, they were saying, around menopause, if we suspect menopause. And in the last 2 years, we've heard, hey, if we're noticing symptoms in perimenopause, that means our hormones dipping down below a threshold that they're feeling problems. The labs might not reflect that because things are a little wonky in perimenopause. But if we start treating symptoms in perimenopause, it's we're going to have the max benefit later on. And plus, we're going to prevent a lot of these chronic illnesses from forming later on. We're going to prevent muscle loss. We're going to prevent mental illness exacerbations, things like that. We're going to preserve relationships and, and just keep feeling more in control of our lives, our bodies, things like that, prevent cardiovascular disease and metabolic disease like diabetes and stuff too. So really, yeah. Now, just in the last 2 years, they've said, hey, go ahead and start treating in perimenopause. Even if the labs aren't smoking gun, hey, something's wrong here. The hormone replacement doses are a third of what we make naturally. So really, it's like not even birth control doses are up here. It's 3 times what we make naturally. Hormone replacement is just raising our threshold so we're not dipping down into it nearly as much, which I think is an important distinction that not everybody understands, so.
I think the thing that you remind me about when I'm managing a male's hormones is that we have to remember that unfortunately we don't have a baseline from when someone's 20.
Right.
Like
exactly.
if we had a baseline on them and knew kind of where and had even like a year's time where we did 3 different draws and you had a real good idea of in your kind of like prime of your life, essentially those prime really mating years. When women are, hopefully in the prime physical,
feeling great,
the way that they feel, like it would be so interesting for me to like to see what these people are at, because I know that some guys probably never are higher than 600, so you get their testosterone up a little bit and they feel amazing. You have other guys that don't really start feeling the benefits until they're 800, 900, 1,000, and it's so. I mean, if we were all the same with you're talking about women, I mean, it would just all be automatic. We'd get to this number, this one number, and that's where we'd feel good. But it's just
we'd be like, boom.
Unfortunately, it's just that's not how our bodies work, and genetics and all these other things that play into it. But it would be so fascinating to me if we could start getting. Maybe I'll have this dream later on. But
what was your level 20 years ago?
Yes, what was your level at your
prime?
Where were you
at?
And then we have
25 before you had children and you're you're stressed and you had bills to pay. Well, the hard thing is too with women is we are not blessed to have one hormone called testosterone that just locks in and we ride it into the sunset.
What's up with that?
I don't know, because it's a lot some days. I tell you what.
We're going to get into that. I think
it's a lot
later on. But testosterone is actually women need it too.
Yeah.
We will talk about that. Yeah. But I think overall, the thing to really remember with women is, if you look at a graph, and I'll flip a paper over and draw this out for patients. If you look at a graph of day 0 to day 30 on a woman's cycle within a month, we are going to be, going up on one hormone and declining in another. And then they're really reactive to each other. When one dips, it triggers the other one to rise and all sorts of things. So we have a very fluid hormonal concept where my progesterone and estrogen at days, whatever, XYZ would not match another woman. That's why there's a million forms of birth control, because there's women who love to live higher on progesterone and lower on estrogen. We all have a body preference that is so hard to match. And that's one of the beautiful messes of hormone replacement, is that it's very symptomatic. You can't have a provider that's like, it's a beautiful mess. It's a beautiful mess. It's a beautiful mess. You can't have a provider say like, well, what? Your number is 50 and that's right in the middle of this range. What do you want from me? You have to have a provider that says, okay, tell me what your symptom is. Let's see if we can fine tune you a little bit. Let's raise you up here and drop this a little and work with you. It's not an overnight situation, but usually once we can get a woman dialed in, especially once they're in menopause and they're not making their own, hormone anymore necessarily, so we don't have other influences, we can kind of get them dialed in. And women are like, then they're like, I'm back. I feel like I know what my body's doing now. So, as much as I love, when I do have patients that need testosterone replacement or we need to address that, and it's so easy, but
it's pretty easy.
I tell my female patients,
it is pretty easy.
Yeah.
Comparatively.
I tell my
which is
female
why we
patients,
invited you to come talk about this.
this beautiful mess. I tell my my female patients, it's like, the big wheels of 1980s, and you got the big wheel in the front, you got the progesterone, and you got the two wheels on the back. Estrogen and progesterone are wheels in this tricycle. Testosterone's in there too. And can you imagine ripping the front wheel off your big wheel? You're not going to go very far. If you rip one of the side wheels, you could.
I like this analogy, but I'm curious, what then would be that little? Remember when they came out that little side brake that you could do like the spin around, move on the big wheel? Yeah.
I don't know. That's probably like menopause. Like if we don't hit it, I don't know.
There's menopause.
There it is.
There you go. That's what you get.
And that's how you feel. Like, wow.
Yeah. But if you rip one of those wheels off, and whichever wheel is the big wheel during your cycle, estrogen sometimes is the big wheel. Oh, now we've switched. Progesterone's the big wheel, meaning it's higher in levels, and which one's the dominant one, dominant hormone for that part of your cycle. If you rip one of those wheels off, you're not going to go very far, because women's bodies aren't men's bodies. We can't just throw a bunch of testosterone in them. Now there are some therapies and some theories that say you can, but really my body's programmed, a woman's body is programmed to have all three hormones as balanced as we can get them with respect of the beautiful mess.
Yeah.
And so it's a lot more work, but it takes a lot more finesse for providers for sure.
No, it's important. And this is like one of the things we've learned over these last 22 years, I guess.
Yeah. Well, and I think even before that, right? So we learned a bunch.
We did a lot. Yeah, we were doing it.
And then we hit the brakes on everything. The so-called big wheel brake.
That was the Women's Health Initiative is the big brake.
Is the brake. And then now it's like almost like we have to relearn it. So that's the one thing that I would point out, Caitlin, is that we talk about women's hormone replacement therapy like it's new, but it actually just paused. It's actually been around since, strongly since the 60s. Yeah. And even it sounds like a lot of the therapies they were using back even in the 60s, 70s, 80s were actually like really appropriate therapy when you're talking bioidentical hormones. And then this one study, once again, just kind of upended everything. And so it's kind of awesome to see that it is coming back. It's sad that we had to kind of regress. And I can't imagine the millions, I'm sure it's in the millions of women that have had to suffer because of that.
So that brought us to, 20 years later, more research done. And there's the book Estrogen Matters. I think that's 2023 that came out. Not too long ago, a couple years. By Avram Burning. The book Estrogen Matters. And it's kind of a direct challenge to all the science in the Women's Health Initiative. It's a big summary of why that study itself was kind of the fears that were generated were overstated, and what really the evidence over these next 20 years has shown, and some of the things that were just simply wrong. And I think he makes that case that millions of women suffered needlessly as a result of not getting that beautiful mess set right during their perimenopausal years.
Right. Well, and all three of us have been in the ER when cute little ladies in their 70s, which, in the 2000s would have been in their 50s, so even 70s really isn't what I consider old anymore. So they were in their 50s, probably menopausal years, when this Women's Health Initiative came out. And we've seen these 70-year-olds come in, say, oh, I barely fell into a doorway, or I sat down on my chair wrong, and they've broken their arm, or they've broken their, vertebra just from barely punching down a little hard on a chair or something. And it's horrifying. And then we'll do a bedside x-ray and we see that these bones are just Swiss cheese, and just the preventative care, breakdown with all of this. And I'm saying, that's wonderful. Even if that were true, even if breast cancer and all these things were true, and they'd kind of, seen some of these things, there's some women who apparently, even in the 2000s, when the doctors called and said, "Hey, I'm going to take you off this," they said, "You can do it over my dead body. I'd rather die of breast cancer. I was miserable. My relationships were breaking down."
Good.
There was a small population that
Yeah.
insisted, because we have medications with black box warnings on them all the time,
Right.
and people still take them. So so there's some strong women that said, I almost lost my mind, or I almost got divorced because my moods were so irregular, or I was miserable. How dare
Yeah.
you? No, I'd rather die of breast cancer, which
Yeah.
says a lot. And I still have women to this day say, "Oh my goodness, like my life has changed so much in the last few months. Like if for some reason I could never have this anymore, I don't know what I would
So,
do
so,
just
so
from
not
looking
only are we
into it."
talking like we made miserable several years for millions of women,
Mhm.
but we created an entire generation
Oh
of
yeah. A
elderly females
whole,
who are
yeah,
not as healthy and far
right.
more frail than
Yeah.
they should have been.
And
So
not just bone health, but we're getting chronic UTIs from vulvar atrophy. All the parts down there change when they don't get good estrogen. It's not maintaining like its tissue shape, or just from all that. So there's a lot of women who come into the ER and they're getting UTIs chronically. They're on an antibiotic all day, every day, just to prevent these UTIs. So that's a huge part too. And that's directly related to estrogen loss. We've got metabolic disease, insulin resistance rising, we've got diabetes. I've even seen women come into me and say, "Caitlin, I eat a Mediterranean diet, I eat fish, I eat organic, and I go walk and work out 4 to 5 times per week. Why is my cholesterol going up?" And I say, "Where are you at with your menopause?" And they say, "Oh, I've been menopausal for 5 or 6 years." And I say, "Yeah, that's part of it." Because when we lose estrogen, everything shifts. Cells aren't happy. They're not at homeostasis. So nothing works as well. So, yeah, it's not just that we're having this whole cohort of women who were in their 40s, 50s in the 2000s. Now they're hitting 70s, plus,
yeah,
and we're seeing them and they're having miserable, and not to mention care issues, because now their adult kids are needing to take care of them. There's a whole discussion
Yeah,
on
it definitely trickles
the
down.
drop.
The
Mhm.
one thing that makes me think of is, and then you think about it, it's even that much worse because you're like, hey, we found out, little old lady, 70-year-old grandma never
Right.
got put on hormone replacement therapy despite being
Right.
symptomatic because they said it was going to give
Mhm.
her breast cancer and everything else. So
Right.
now she has these really thin bones, whatever.
Mhm.
Her and her husband have struggled for 20 years because she just
Right.
feels horrible. All these things
Mhm.
that we,
Right.
predictively could have been prevented. Now you're in a situation to where you can't do it. Now those
Right.
risks are
Yeah.
significant because
Yeah.
if we find out their bones are thin and we have a significant osteoporosis, now we're
Yeah.
just stuck.
yeah,
Now
Now
you're
we're
like, well,
you're not going to
chasing
get
it.
sorry.
that better. You're not going to make that.
Yeah.
Yeah, we're
Your
not going to
bones aren't going
improve.
to
Yeah.
be 20 years old again.
And we have
Well,
medications that we know can
we're chasing
help
it.
with
Yeah.
some reuptake and things like that. But you're really just so far
Right.
behind the problem that we're just
Right.
like, geez, I hope a strong wind doesn't come up and break your hip.
Right. And, it's like spitting on a forest fire. Like you're not going to get very far. And I don't personally
Which
love.
as a previous wilderness firefighter, that doesn't work out
Doesn't work.
in the way
Neither
here.
does, yeah, like it doesn't work. But I think that, I am personally, I would rather be preventative and proactive. I've been raised
Yeah.
in a world where you don't just take a pill, you do things to prevent. You do your,
Yeah.
you do your
And we're going to
regular
get into a
maintenance.
bunch of those things here a bit
Yeah.
later as well. So,
Yeah.
so now, where would you say that our consensus is? I mean, it's my understanding now, kind of major medical organizations, including the Menopause Society,
Yeah.
pretty much now strongly favor hormone
Yes.
replacement. Within
Yes.
10 years of menopause onset, but certainly not the
Right.
blanket. Oh no, don't do it. It's bad for you. You'll get cancer.
Oh, yeah.
It's much more individualized, and talk about women's age and the timing and their symptoms and their personal history and their
Right.
goals. But I
Right.
think the consensus has now shifted, or is shifting much more towards everybody agrees that this is a good thing at the right time.
Right. And the biggest thing is what we learned what not to do, right, in the Women's Health Initiative. And so we can very confidently say hormone replacement is safe for the majority of women. Now there's some contraindications
Yeah.
if you've had an unprovoked DVT-PE. So like meaning we didn't just have surgery, we didn't just lay in a bed because we were ill, kind of things, clotting disorders. If we have breast
So
cancer,
a
that should,
deep vein blood clot
yeah,
just out of the blue,
blood
not
clot,
associated with
if we've
some
had a
event.
stroke, a heart attack. But really, when you look at the population, very few people have had an unprovoked DVT that we can't explain, or PE that we can't explain. Very few women have breast cancer in the grand scheme of women. The number one killer of women is not breast cancer, it's cardiovascular disease. Boom, bombshell. We have to prevent that, right? So if we've got breast cancer, sure, we treat that smaller population. We say, hey, we got to do things a little different. Vaginal bleeding after menopause, we got to make sure there's nothing going on down there. We first things first, we got to make sure things are safe. History of stroke, history of recent heart attack, severe liver dysfunction. But really, when you look at all those things, you're like, I don't know the exact numbers, but the Menopause Society of America says that's a very small population. So having a good conversation with women and saying, hey, this is safe for most women overwhelmingly, but because, and bless their hearts, these providers, these primary cares, they're so busy just trying to get people to take their diabetes meds and their blood pressure meds and just trying to get basic health stuff right. And they're losing time with patients because insurance is requiring more and more and HMOs are requiring more and more. So bless their hearts, they're doing a lot. But really, when these providers who are now practicing were going through med school 20 years ago, and they were being taught through this women's health initiative that hormone replacement wasn't safe, that trickles into practice. And it's hard to relearn big guidelines that have such big implications. It's scary. No clinician wants to give their patient cancer. So changing, the more we talk about it, the more we change that narrative. I'm trying to do that right now so that my daughters have no problems with hormone replacement. Nobody even blinks an eye at it. But you'd be shocked how many women come into my clinic complaining of all these problems, the symptoms of menopause, but they're still scared to even talk about hormone replacement. And I don't push
Yeah.
it.
And it
It's
takes some time,
multiple
it takes some
conversation.
education
Yeah,
to
it's
do that.
multiple
Not
conversations.
only with patients, but with providers. You mentioned when you went to medical school, it got me thinking. 30 years ago, I was halfway through medical school. Like I'm in the middle of medical school 30 years ago, and now you know my son Pete. He's a podiatrist. He was started just a few years ago, and I remember one day he was on the phone. He was talking to me, and he says, "Dad, we're learning things that were like not even known. They weren't even discovered when you were in medical school."
Rude.
And I'm like, oh my
Kids.
goodness, I'm that guy now. Like, right? It's not just, it's not just the patient. Like your provider's gonna need to keep up on this a little bit, and it takes some serious effort to kind of stay abreast
to stay up to date
of the information and how to best serve your patients.
You would expect your cardiologist to keep up to date on, cardiovascular management, heart attack, stroke. You would expect them to. And this is a big primary care thing. Prevention, preventative health is primary care. And I suspect, as the narrative changes and this older population of providers, I'm not talking about you, Sorensen, but as this older population works out and these newer, younger ones are coming on in, they're going to be taught different things, and it's going to be like second nature to them. And I think that's what's going to be the biggest difference for my kids. And I've already seen some providers that come out of medical school and they're just like, oh yeah, well, if you want to try it, let's try it. They feel a lot more comfortable. They feel a lot more comfortable asking for guidance from other practitioners that do it a little more often. But it's going to take time, but I'm happy with what's even happening now. So
awesome. Okay. Well, so kind of summarizing that, the Women's Health Initiative study changed history.
Yes.
But its interpretation has probably caused more or as much harm as it prevented.
Right.
We now have some better science, better formulations, better understanding of timing, and that's kind of reshaping what we have to offer women throughout the course of their life. Does that sound right?
Absolutely. Okay. Perfect.
Well, good. I think that's a good summary of kind of the landscape of where we got to. Yep. We're gonna kind of just cut and keep Caitlin on for some more information. We're gonna get into next time, sort of a little bit more detail about the hormones over the course of a woman's lifetime. It's not as simple as just have some more testosterone, bro.
Yeah.
No.
All right. Well, with
No.
that, we will be back next week.